Thank you. Thank you very much for giving me the opportunity to speak to you today about this very important issue and an area that is new to Harm Reduction International, and I think is a very new area of work in general. I think I'll be as quick as I can because I'm fully aware that I'm all that's standing between everybody and the end of a long day. Injecting drug use amongst adolescents has been largely overlooked in relation to HIV prevention and HIV risk assessment. Injecting drug use amongst adolescents, it's important, I think, and this reinforces a lot of what's already been said on the panel today. Injecting drug use amongst adolescents is a behaviour that takes place amongst many overlapping vulnerabilities. It doesn't take place in a vacuum. And this includes other forms of drug use that may not be injecting drug use, sexual activity, street involvement, histories of abuse, and other risk factors. I'm aware that drug use amongst adolescents can be a sensitive topic. And within this, when we talk about the issue of injecting drug use, this becomes inevitably more challenging for providers and for the community. And while the primary goal in most countries and within many communities is drug prevention, often interventions that seek to reduce risk, including HIV risk, without requiring cessation of use, may not necessarily fit within these frameworks. And while controversy and sensitivity around this topic is entirely and completely understandable, it mustn't lead to paralysis in ensuring that we provide evidence-based HIV prevention services for the most vulnerable young people in our societies. It's also probably worth pointing out that many young people do use a drug of some sort in their lives, and this may not necessarily lead to the need for treatment or care. But in the case of injecting drug use, it's a small but high-risk population. And HIV isn't the only risk or health risk that is experienced by this group, but it's one that we're focusing on the context of the work that we've been doing. But there are many other risks in terms of hepatitis C, overdose, as well as wound botulism and other health-related risks. Harm Reduction International attempted to compile a global data snapshot of the population of adolescents who inject drugs. Our first priority was really to try and better understand this epidemic amongst young people who inject drugs. How large or small is this issue? And we did this because, and I'm quoting a presenter I heard yesterday, actually this is not my line, but people count when they are counted. When we don't know the numbers and we don't see these populations in terms of epidemiology, donor priorities perhaps may not shift in this direction. We may not be able to produce programs, and we're really left with a blind spot in terms of our understanding of an issue. There are 15.9 million people aged 15 to 64 who inject drugs across the world, and around 3 million of those are thought to be HIV positive. And the first thing to say on this issue is I'm sorry to say that I can't provide you with a global population of those under the age of 18, because this is an impossible task, it appears. The data on this issue is so poor and so patchy that to derive a global estimate has proved to be impossible. Unless anybody in the audience has one, in which case I'd very much like to speak to you today. The estimation of 15.9 million people doesn't include those under the age of 14, first of all. And while initiation into injecting drug use can and does happen under this age, it is uncommon, but it does happen, so we're missing a substantial proportion of young people. And I think most importantly, the figure for 15 to 64-year-olds doesn't disaggregate data for under 18s. Therefore, we are unsure in terms of this particular figure how many people who inject drugs are aged under the age of legal majority. And this is due to a number of reasons, but the main issue is that there are two main conduits for gathering data around drug use in young people. The first, in terms of data collection, is often large school-based surveys which gather data on drug use amongst young people. These are cost-effective, and when they use the same methodology, they can allow for cautious comparisons across countries, so they do provide us with some useful information, and they are important. However, they're very unlikely to capture data for this particular population. First of all, young people who happen to inject drugs often are not in school, not in employment, education or training, so they are missed in terms of this data collection activity. And secondly, there's often a fear of confidentiality or a lack of anonymity when answering these questionnaires. So if you are engaging in injecting drug use, which is a highly stigmatized and criminalized activity, it's possible that many young people won't disclose it in this setting. Therefore, again, we're missing them in this data collection system, making it difficult to build a response. I think also importantly, often some of these surveys are driven very much with a drug prevention angle, and they gather important data in terms of types of drugs that might be used or frequency of drug use, but sometimes they lack the ability to capture information around risk reduction strategies that we could put in place in order to work with this group. In terms of data collection for HIV and AIDS, which is another area where we looked to attempt to gather data on this population, disaggregation for age data around disaggregation of data around HIV/AIDS indicators is extremely rare. Age indicators account for under 25s. Again, this is useful and extremely helpful, but it doesn't particularly help us when we're looking at those under the age of legal majority, because that age range is then not disaggregated down again. And it obscures key differences in vulnerability, in legal status, and in access to services for those under the age of legal majority. In terms of reporting at a national level, reporting for under 25s is an important start. But in 2010, less than 1/4 of countries who submitted data that disaggregated for under 25s who inject drugs. So less than 1/4 of the countries that submitted that data submitted anything for those who are under 25. There have been some important contributions in this area, notably from UNICEF, some academic reports, and from the Eurasian Harm Reduction Network, all of which point to a need to develop robust methodology which harmonizes collection across national and international systems to ensure that we're disaggregating data for those under the age of 18. However, there are some national and regional and some subnational studies which we can point to start to get an idea of what we're dealing with in terms of population size estimates. So in Ukraine, which has a large population of people who inject drugs, led by a couple of important studies. The reference is below if you want to take a further look. It was estimated that around 50,000 young people in Ukraine under the age of 18 are injecting drugs. Importantly, I think it's worth thinking about when we're thinking about risk reduction and harm reduction for this group, that as you can see, for those who were reached by one of the largest and most well-funded harm reduction services in the world, less than 1,000 young people of the 50,000 estimation are being reached by this service. And we'll get on to the barriers in a minute, but I think it's worth thinking about the fact that clearly young people are not accessing services. Across the available studies that we do have, and what we can say is why there is extremely wide geographical variation, there are a significant number of young people who inject drugs in adolescence. And I think this can be seen particularly in regions where we know there are large populations of people who inject drugs, such as Asia, Central Asia, and Eastern Europe. And from the available studies, there's some important, we can glean some common themes. For example, across many studies, low ages of initiation into injecting drug use were reported. So for most common in the age range of sort of 15 to 19 years old. In Romania, for example, almost 1/4 of adolescents reported initiation into injecting drug use before the age of 15. In Bangkok, the Philippines, and Ukraine, the average age is 18. Nepal and Bangladesh, 17. Albania, 16. In terms of proportions of population size estimates around how many young people of those size populations are injecting drugs, in Burma it's thought that around 37% of people who inject drugs are between 15 and 19. But again, we see really large variations between regions. In Latin America and in sub-Saharan Africa, we see less young people who are injecting drugs. Then again, the data in these regions in general is quite poor, so it's difficult to know if we're just missing these young people. In terms of specific differences, in terms of the risk environment, there are important differences between younger people who inject drugs and their older counterparts. Younger people are inevitably newer to injecting. They often do not have the same knowledge of safer injecting practices and therefore HIV risk. They often don't access, as we've seen, traditional harm reduction services, therefore are perhaps not accessing education or sterile injecting equipment perhaps as quickly. It's also been reported quite frequently that many young people don't necessarily identify as a drug user. They continue to enjoy using drugs and they don't put themselves in that category, therefore making it more difficult for outreach services perhaps to work with this group. They're also often using different drugs. We're talking about injecting drug use in the context of this discussion, but many young people are using amphetamine-type stimulants. There's a high proportion of solvent use, and this throws up very new challenges in terms of treatment, care, and harm reduction services for young people. There are specific groups of young people who have been identified at increased risk, in particular those who are street involved. Also, young women who use drugs have been identified at an increased risk of HIV transmission. Young people who are from minority ethnic backgrounds, particularly in Eastern Europe, there's a high proportion, an overly high proportion of Roma young people who are identified as having increased risk. And often they are young people not in education, employment or training, and those young people are consistently found to be overrepresented in this group. Yes, also many young people have reported harassment by police or law enforcement officials, making it less likely for them to identify themselves A, as a drug user, or B, use traditional harm reduction services, meaning that pharmacies or other types of services are where they are acquiring perhaps injecting equipment or information. Young people with a history of abuse or in conflict with the law, mental health issues or street involved, as I've said, are all at a higher risk. And these variations have also been associated with an increased risk of HIV and Hep C transmission. Just a quick slide to show some of the data that we do have on the risk environment around young people. So you can see here in Indonesia, data has been disaggregated by age in terms of those who report sharing needles. And the 15 to 19-year-old bracket, you can see that 52% did report needle sharing. This is a much higher amount than for their older counterparts. I think it's important to point out that in the case of working with this group, context is key. Some guidance does exist in terms of working with young people in drug and treatment and care and substance misuse, as you can see from the NHS UK guide at the back there. But what we're talking about is young people often in different regions where we're looking at issues of abject poverty, where we're looking at systems that perhaps don't have fully formed healthcare systems in place as yet, and how transferable are the good practices that have been developed, such as the ones you see over here. So in order to try and start thinking about this, a coalition of organisations, including ourselves, have started to develop some thinking around how harm reduction services can perhaps better meet the needs of this group. The existing comprehensive package on HIV and injecting drug use, which is a comprehensive package of 9 core interventions, which when put in place, are recommended to reduce HIV incidence amongst people who inject drugs. This wasn't developed with adolescents in mind, and each of the 9 interventions is much more difficult to deliver for this age group. I don't want to understate the complexities or sensitivities that this involves, but essentially providing some of these harm reduction services for young people is something that we would recommend. So just a quick overview of the work that we've been doing. So ourselves, Save the Children, Youth Rise, and the International HIV/AIDS Alliance have come together in a coalition to develop a new tool for harm reduction services to try to become better prepared for working with this group. It's called Step by Step. Yes, this is us, and this is why we're doing it, all the reasons I've just mentioned. Really what it's to do is it's to try and help harm reduction organisations navigate the very tricky ethical, legal and practical dilemmas that will be thrown up when working with under 18s who use drugs. It'll help organisations explore attitudes about how people feel around working with this population, understand the needs of safeguarding and protection of children within the services, assess the current capacity of the service to work with young people, map available services for backup and support, and work to develop policies and procedures for working with this group. And we have put together a variety of scenarios of the kinds of issues that perhaps might be thrown up when working with this group. Here's one of them. It's been developed such as you can see here. We are currently pilot testing this tool. It's been pilot tested in Nepal. It won't be pilot tested in Ukraine now, unfortunately, due to the changes in the situation there, but we'll be pilot testing in Romania and Kenya, and we hope to be able to finish it and launch it at the end of this year. And unfortunately, we did have a workshop this morning, so bad timing in terms of the way that today worked out, but we can give you more information if you would like some. Thank you very much.